much for joining us in today's webinar. The topic today is Healing Across Borders, Substance Use Disorder Treatment for Refugee and Newcomer Adolescents. And our goal is to move beyond the one-size-fits-all models to provide healing that respects their unique journeys. These are the areas that will be addressed in today's presentation. Now, I am pleased to introduce today's speaker, which is Dr. T, who is also a clinical consultant with the RMTAC team, and he brings a wealth of knowledge and experience in supporting diverse communities. Dr. Trenton Fedrick will be guiding us through the discussion and sharing valuable insights.
Good afternoon, and thank you, Luz. So we're going to first identify at least 3 cultural systemic barriers, compounded, steeped in things like compounded stigma, language access, distrust of authority. And we're going to look at those things that prevent the refugee adolescent from assessing treatment. One of the other learning objectives that you should be able to achieve is to apply trauma-informed screening techniques that distinguish between recreational use and self-medication for migration-related PTSD. You should also, at the end, be able to utilize a family-centered approach to treatment that respects the collective culture values and addresses the acculturation gap between the youth and the parents. We're going to start by first looking at the refugee context and the triple burden. Refugee youth don't just walk in to offices with a substance issue. They carry a triple burden. First, it's the pre-migration trauma, war, loss, those things that may have occurred in the journey. Second, the stress of fitting in while keeping their home culture. And then third is the systemic barriers like language and poverty. We have to view substance use through this lens of survival and coping. When we talk about barriers to care, why is the engagement rate low? In many cultures, SUD carriers, substance use disorder carries a compound stigma, shame for the individual, the family's honor. So when we think about an adolescent or a teen refugee or newcomer, we're talking about someone who is also carrying the burden of family members that may not even be here with them. Furthermore, many come to this place where the system is an instrument of harm, where the police are a part of the issue, where the courts are a part of the problem, making them hesitant to share personal struggles with government-linked counselors, possibly believing that you will pass along information. Lastly, if a family is worried about rent or legal status, therapy is often, it often feels like a luxury. It often feels like something they can't afford. Research shows a high correlation between migration-related PTSD and SUD. For many newcomer youth, substances, alcohol or cannabis are used as medication to quiet nightmares or society anxiety. When we treat the substance, we must use the underlying trauma simultaneously, or relapse is almost certain. The information I just gave you came from the relationship to drug and alcohol use in international sample of Latino immigrants. And looking at the study, it looked close at this relationship of PTSD and SUD use. And one of the ideas that it talked about was the fact that alcohol and these substances are often easier to obtain to address PTSD than medication is for a migrant who may not have medical insurance or any other way to get medical care, specifically mental health care. We want to take a look at culturally responsive screenings, right? A standard screening tool, and when we talk about culturally responsive, those screenings that take into account the culture that we're dealing with, the environment that they come from. So standard screening tools like the CRAFT 2.1 are great, but with refugees, the delivery matters more than the form, right? So how you actually deliver the service, how you actually deliver the situation. And since this is a self-administered test, how you present it is the biggest part of the delivery for you as a professional. Avoid interrogation style questions. Instead, use soft inquiry. How are you managing the stress of school? Do you use anything to help you sleep or feel less worried? Explain why you're asking. Specifically, that it's for help, not for legal reporting. Let's take a closer look at the Craft 2.1 as a screening tool. And taking a closer look, seek ways to translate other tools to work with refugee and newcomers, right? So there are other tools that are out there. All of Beck's tools is just like the Craft, have been well translated. So look out for those other tools and think about how other tools can be translated and used for the population you serve. The Craft 2.1 is a validated health screening tool. So it's designed for adolescents and youth ages 12 to 21 to identify substance use, substance-related risk like impaired driving, and potential substance use disorders. And the 2.1 version is updated from the original Craft, replacing yes and no questions with in the first section with frequency of use questions to improve accuracy. And the form is typically divided into two main parts. If the screen is the 2.1 version, it also includes additional section for nicotine and vaping. When we look at the structure of the Craft 2.1, each letter is in the mnemonic, stands for a specific risk factor. Car. Have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? Relax. Do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? Now, the car question, you may want to substitute, and I've been trying to think of a substitute for that in case they don't have access to a car. But it's also important to look at the fact that the car question does ask if they've been in the car with someone who was high or and I just move back to that for a moment because that's one of those ones you may need to kind of come up with something a little different. Do you ever use alcohol alone? Do you ever use alcohol or drugs while you're by yourself or alone? Do you ever forget things you did while using alcohol or drugs? Do your family or friends ever tell you should cut down on your drinking or drug use? And then the T is trouble. Have you ever gotten into trouble while using alcohol or drugs? One of the most important things when using the Craft, particularly effective for adolescent refugees and newcomers, is because it bridges the gap between the clinical screening and trauma-informed care. So for youth who've experienced displacement, substance use is often a coping mechanism for unseen stressors like acculturation, isolation, or past trauma. Now, here's how providers can use the tool more effectively with the population. The first thing is to look at linguistic and cultural accessibility. Good thing about the Craft is it's widely translated, validated in a dozen languages, including Arabic, Dari, Pashto, Spanish, and French. And that's crucial for newcomers because this reduces the things that can get lost in translation. So standardized translations ensure that nuanced concepts like using to relax versus using for fun are communicated accurately. Validation across contexts. It's been psychometrically validated in diverse international settings, Nigeria, Argentina, Indonesia, proving that the core risk indicators like using alone or getting into trouble remain relevant across different cultural backgrounds. This is often extremely true for newcomers and refugees who are very family oriented. So when things like an increase in trouble or an increase in being alone come up, you see that as a risk factor. Enhancing trust and honesty. The refugee youth may be hesitant to disclose substance use due to fear of legal consequences, deportation, or cultural stigma. The good thing about the tool is it's a self-administered tool, and research shows that adolescents are significantly more honest when they complete the Craft on a tablet or a paper rather than answering a provider face-to-face. I know often we have tools that have to be administered, but this is one that they can fill out on their own. So for newcomers, this also allows them to read at their own pace. One thing that's important in the self-administration is give them room, don't crowd them. If you may be doing multiple screening with multiple adolescents, give them a little space. them some space. Don't stand over. Frequency of shift. Versions 2.1 ask how many days did you use rather than yes or no questions. This normalizes the behavior, making it feel less like a test and intrusive, and they might fail, and more like a routine health check. Using the craft 2.1 with refugee and newcomers, you want to be identifying substance use as a coping tool, right? So you want to recognize where they're utilizing the substance just to deal, just to cope. For the refugee youth, the R, the relax, and the A alone, these questions have a high value diagnostic markers, right? Newcomers often use substances to manage symptoms of PTSD, anxiety, or stress, or fitting into a new school system. If the athletes won't take me on, the guys that get high will, and then that concept of alone. In some cultures, social drinking and smoking is normalized, but using alone is a red flag for self-medication and a higher risk of dependency. From a best practices perspective for providers, when using the craft with this population, follow these guidelines. Explicit confidentiality. Before handing over the form, explicitly state that their answers will not affect their immigration status or be shared with their parents within the bounds of the safety of law. Now, I recognize if you're SUD, substance use disorder providers, you may look at, but the confidentiality that states the one place where an adolescent can sign themselves into treatment without a parent's approval is substance use disorder. They can't do it with mental health, but they can do it with substance. Like they can go in and sign themselves into treatment. And part of the reason for that is because most of the time adolescents are not coming to treatment. But what we have to remember when working with refugee and newcomer adolescents is they're used to family involvement, and we want family involvement. But we want to also let them know that we will maintain certain points of confidentiality so that they do feel safe. And I mentioned this earlier, contextualize the car question. For some newcomers, the car question might be less relevant. If they don't have access to vehicles, you may need to broaden the context to include other forms of transport, because you want to look for something that would be just as risky as driving a car under the influence to get the point across, or at least close to that. Avoid lecturing. If the screen is positive, use motivational interviewing instead of saying you should stop. Ask, how does using weed help you deal with the stress of moving here? And what are the downsides you've noticed? The family-centered model. Western therapy is often individualistic, but refugee cultures are often collectivist. If you exclude the parents, you lose the patient. However, there is often a acculturation gap where the child speaks more English and adapts faster than the parents. We act as a bridge, helping the parents understand that SUD is a health issue and not a moral failure, while helping the youth maintain cultural roots. I know that often, I've been in the field of substance use disorder since 1992. But the hardest thing in my years in Western culture is getting the parents involved. But the best thing about it is once they were involved, it was often the most powerful thing that occurred in the treatment process. Even when I think about working with my Latin clients, it was difficult because their families were so westernized. It was difficult to get, our society doesn't emphasize family the way a lot of places do. But I'm saying that to say that when I did get family involved, relapse rates went down, going to school, being present in school went up. So the one good thing that I think can come my work with refugee and newcomer adults, one of the things that always made it more rewarding was the fact that often I would have wives who wanted to be involved, older children who wanted to be a part of what does daddy need to do for recovery. So I could imagine having an adolescent and having involved parents, because I know what it's like to have an adolescent having involved parents that wasn't a refugee or newcomer. and how the difference that made in that adolescence. So we don't want to move them away from their roots at all. We want to try to get them to actually, in many ways, embrace their roots, because that's going to keep them a lot healthier. Then let's look at we want to look at evidence-based and promising practices, right? So that's which are more best practices stuff, what works, right? Multidimensional family therapy is highly effective because it looks at the environment. So when we talk about multidimensional family therapy, we talk about the environment. When I say environment, I want you to think about not only a full community like we often think, and then as the therapist, you are a therapist, so you're probably thinking the family environment. But think about the environment of the journey, the environment of the current family, because remember, you may have an adolescent here who is not here with their parents. They're staying with an aunt or a distant cousin, or that's an adult or something of that nature. So when you're using the good thing about multidimensional family therapy is it brings in the extended family. It allows a place for them, and kind of provides a roadmap. Also, when we talk about evidence-based motivational interview, it's an excellent for building rapport without being confrontation. And if you think about a client who may have come from a oppressive society, the good thing about motivational interviewing is its roots comes from person-centered therapy. So in motivational interviewing, you allow them to take control of the situation, right? You allow them to tell you what they need. You're not telling them what they need. Even though I understand we get rushed, and we come in the door of our organizations and we open the door and we come in and we grab the clipboard and we look at 70 faces sitting in chairs. I'm currently in Texas, but I come from Chicago. So we look at 70 faces sitting in chairs and we go, wait, everybody needs something. And then we run over there and try to rush them into it, you know. But, we become authoritarian in doing that. We utilize our motivational interview, right, to build that rapport. We should also consider cultural recovery capital, right? And that's incorporating faith leaders and traditional healing practices where appropriate. Build a relationship with the local grocery store of the community. I'm a Chicagoan, so in certain areas of Chicago, Pilsen Little Village, and some other places that I've worked, where the guy at the little grocery store, because they were often food deserts, so everybody had a little grocery store, but the guy at the little grocery store, especially if he was of the community, he knew more about what was happening in the community than anybody else, and he was a large part of things occurring in the community and providing a certain amount of support. You can't necessarily bring the grocer in, right? That's not what I'm talking about. But he can point you to community leaders that can help you with certain things in the community. You may find out that, Miss Johnson's son, no, that's okay. Miss Johnson's son does translates for everyone over here, in the Korean community or the Black Latino community or whatever. So you'll get more, you may get more information. So your organization may want to bring in those community players and stakeholders. Let's talk about action steps for counselors, right? So your 30-day plan. First, ensure you have professional medical interpreters, not family members, for sessions. Stay away from family members. As helpful as they can be, they may translate your information in a way that's not healthy for anyone in the room. You need to have professional interpreters. Even if there are other social workers that are bilingual or multilingual in your organization that act and assist as interpreters, that's great. There are so many organizations around the country that provide interpretation services for clinical situations. Make a relationship with them. If you're in a small area, you may need to, and when I say small area, I mean, like, now that I've worked in places like Oklahoma and even in the DC area with some of the smaller towns going into West Virginia, I realized that the interpreter, there may only be one actual organization that provides interpretation. And it may be the town over, right? So you need to build a relationship with that person. And that may mean, going to town over and having lunch with them and saying, listen, I may need this, or is there a way that you can come and be there a couple of days a week to help? Um, the second, third thing is to remember, hungry or housed and insecure teen cannot focus on sobriety. If I don't have a place to live, or I don't have a place to rest my head, if I'm not eating, I can't focus on sobriety. So provide holistic referrals, right? We are at the question and answer point. I'm going to ask you for any questions you may have, but I'm also going to turn it back over to Luz.
Thank you so much, Dr. T. That was excellent information. And thank you for your wealth of knowledge and information. Like Dr. T mentioned, this is a good time to spend a couple of minutes answering some of the questions that you all may have.
And I'm going to talk about this gain cue because I had a little information, but I haven't used the gain cue. But I love the fact that it aligns with the DSM-5 and the NASAM criteria. And if I'm not mistaken, I think you said that you can be tabulated by computer, which is great. The one good thing is that we have to recognize that technology is everywhere. We have to leave our stereotypes and our biases. Young people are attracted to technology. If we can put these different tools on a tablet, they'll be more interactive to that. I mean, when I'm in other countries, this little baby computer is everywhere, and everybody's doing everything with it. So having tools like this that are computerized. The other thing is it probably gives you fast results. Like one of the things when I was talking earlier about the craft, that if you get like so many zeros or so many marks, you really need to take a closer look. The real point is the quicker you can tabulate whatever the situation is, the quicker you can come up with a formulation of response. How am I going to respond to this? How am I going to assist this person in addressing these maladaptive behaviors or these issues, right? What role, I do need to go forward actually, because I want you all, I'm answering questions. I want you all to take our RMTAC survey, because we need that survey so we can continue to be funded, so we can continue to give these great workshops, so I can continue to have a ton of information and not know how to spread it out enough, all that good stuff. That was to make you laugh. Okay, but what role do family or community play in supporting recovery for newcomer and youth? And that goes back to what we were talking about. When you start talking about the refugees and newcomers, we're talking about people who more often than not, I mean, there's very few individualistic societies outside of the United States. I'm just going to be honest with you. They come from where family is important. There are people in their family they will listen to. And when we're talking about adolescents, they were sent here to be with some family members. It's important you bring them in. It's important you bring them in not only to help the adolescent, but let's say the adolescent is here without their mother or father, right? So I'm here at a distant cousin's house. Well, I love my distant cousin. Don't get me wrong. I'm here at auntie's house because I love them. They're assimilated. They're all Americanized, right? And I've got things happening with me, and now I got to translate it back home. Having the family involved allows things to be translated back home healthy. So you're not creating a whole new worry in his family there, which will do that's just going to compound the stress that the client may feel. Because anything that's going to help this person address these maladaptive behaviors, and most of the time the need in that situation is a need for support and not feeling alone, because they're usually dealing with issues of trying to fit in, especially when we talk about adolescents and young people. How can providers build trust with refugee adolescents who may feel unsure about seeking help? That's the hard. Because the thing about part of the reason why there's a law here in America that allows a 12 years old and above to sign themselves into treatment is because when an adolescent finally comes to somebody and says, I need mental health or substance use help, they really, 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 really need that. That's not saying that there aren't other adolescents that need the help, but more than likely, that at that stage in life, that's a stage in life where you feel a little invincible. You work out of your feelings, and although these things may really be a problem, you won't see them as a problem because Johnny's doing it, and Willie, and it only takes one other person to be doing it. But you'll have two or three doing it. Well, it can't be a problem. So if an adolescent actually comes to you and says, I'm ready for help, that's a very not only mature move, but it's more than likely a very desperate move. Probably a certain amount of desperation because they're at a point now where they really don't have control of the situation. And adolescents often always feel like they're in control because they're trying to grow. So they're trying to control things. I mean, I got this. I lost control. That's why they're always losing control, right? Because then it takes time for us to learn that you don't have, the only thing you have control over is yourself. So one of the best things to do is to work with schools. There is a organization I worked with, Haas. And one of the things that they would do is put counselors, they had adolescent counselors that would go to the school and would kind of like just kind of be around and provide service. I think they would be there like 3 days a week for like 2 hours, right? So they weren't there all day. And they would go and just kind of be there. And if the local school counselor had identified people that they thought they might go talk to them, give them a little something. With refugee and newcomer adolescents, the main thing you want to do is create areas of safety. What's going to bring them to ask for help is safety. And one of the things that comes with safety is familiarity, right? Are there people that are familiar to them? And I don't necessarily mean, I know John, or I know, or I know Juan, or whatever. That's not necessarily what I'm saying. I'm saying when I walk in here, is there someone who looks like me, who eats what I eat, who can understand why I'm so uncomfortable, why I'm doing this to fit in, right? So that'll also draw them in because they'll see a place where there is assistance that can come. The other thing is to work often. So in urban areas, you've got so many resources. And I'll get to how effective handouts are. Actually, handouts and pamphlets are extremely effective, and brochures. What makes them more effective if they're designed in a way that doesn't feel intrusive. And what I mean by that is that here, I've got some help for you. Just come in, and I'm not, it's showing the best way you can show that it's not overwhelming. But I haven't worked in a lot of rural areas. I've worked mostly in urban areas. So there are large contingencies of organizations you can work with. But the thing is, what we often do is we don't connect to those resources the way we should, right? But a lot of times these adolescents and do, like the community center or the YMCA. In Chicago, the Y has different stuff for refugees and newcomers. So this becomes a place you can go and have that conversation that you might not be able to have somewhere else, and say, hey, we're offering some help. You can give out some of those brochures and some of those pamphlets, especially, and the person emphasized culturally appropriate, because that's important too. So make sure that you created those brochures that you've given out that talk to the population you're serving. Well, a lot of them are also not used to having help, that is very true. That is very true. Often they're not even used to having those kind of resources. I guess it was last year. Last year I was in Ghana, West Africa, and I was walking past the clinic. As I was walking past the clinic, I could hear this woman scream, and it was a visceral scream, and you could tell somebody had either passed or something had happened. And what I realized, because I go back and forth, that what I realized is that they don't have like psych aides or people like that to kind of go and say, hey, come over here, let me talk to you, so that everybody else doesn't go up in services. So and that seemed like for me, coming from Chicago, places like that, that seems like a simple service. That seems like something you don't have a psych aide, you gonna have some social worker, somebody, but it's not. They don't have all those resources. We take for granted the number of resources that we have available to us, and they don't have all those resources. So we also have to be prepared to be a little more giving in what we do. Like one of the things that I used to talk to, I supervised a lot of SUD programs, and one of the things I used to have to talk to people about was, if your client comes in 15 minutes late, you don't tell them you don't see them. You tell them, well, Amar, you used up 15 minutes, so I'm sorry, brother. You only got 30 left, because I get that last, but I'm gonna give you your time, because you don't know what he had to go through to get there. You have no idea what he had to go through to get there. You don't want, and the thing about, I'm a clinical psychologist, so I know that when professional psychologists are working with people with insurance, they do stuff like, oh, if you don't show up, I still get to charge you and I don't have to see you, right? I'm not sure about you all. Maybe y'all got private practices, but I worked with communities. That doesn't work. And respectfully and responsibly just talking to them about the types. So that's one of those little cultural things. I'm thinking about community cultural liaisons. Could you have an insight on how they can be helpful and supporting? Actually, those would probably be great. Some type of bridge. So the question says, I'm thinking about community cultural liaisons. Could you have an insight on how they can be helpful in supporting these adolescents? And that's that's kind of like a psych aid. And probably the best thing you can do is, if you've been working with this population for a long time, and you have alumni that are still young, bring them in, give them some simple training, because you're not asking them to do the work. You are not asking them. That's not what you're asking them to do. You're asking them to introduce help. So I think that would actually be great. And I've worked with some programs. They had what they called outreach workers, right? And that's basically what they did. Similar to peer support. Yeah, if you can find adolescents who maybe came at 13 and now they're 17, they'd be perfect, right? They came there at 13, they're 17 now. They've assimilated and done all the good stuff. I look like I see peer support with a frown. You're not sure if that's possible. Right. I guess, and I'm taking that little frown as you're not sure if that's possible. Yeah, that's why I suggested somebody who's been here a few years, that's kind of gotten the lay of the land. The other good thing about working with people from the community to help teaching them about confidentiality and about what we do and how we do it is that it helps to lower stigma. Yeah, I was kind of going there. So I'm gonna stop. Any more questions?
No, those are it. But again, we will send out the PowerPoint, right, with the references that are on the presentation, and we will be gladly to answer all the questions more detailed in a clinical consultation request.
And also remember, we are RMTAC. So take some time and come to RMTAC and put in one of those CTA requests. Fill out our survey so that we're able to do things for you. We can do consultations with you where we're actually working directly with your program, helping you to develop programs to work, doing trainings around certain forms of therapy. We got people who do brief solution focused stuff. I'm person centered. It's some good folks doing some good stuff, you all. RMTAC.org. Navigate over there, go to that little blue box, hit it, say, I got a CTA request. I want you guys to come and help us, and we'll come and do that for you. Thank me for the presentation. Okay, so I'm glad you mentioned that. And this is something I said I was going to do every time I did this. When it comes to CEUs, I've been a trainer for CEUs in Illinois for many years. And one good thing about it that I've always known, unfortunately, all of our programs don't have CEUs. We do have some coming up that will. But what you can do, because the PowerPoint lists out exactly what we've done, it shows you to let you know how long you were doing it. You were here for an hour. So I would say when you get situations like this, hold on to the materials. Make sure you get the materials. If there's a syllabus, and like with this, there's no syllabus, but there's a PowerPoint that acts as a syllabus. Get that material, because if you're short, it's better to pay $10 or $12 for them to accept it as your own CEUs and get those CEUs. And this you can do that. I've never seen them turn down, especially stuff like this. I've never seen them turn it down.
Thank you, Dr. T. That's such an engaging presentation, and thank you for everyone who attended this webinar.
We really appreciate you all, and we look forward to seeing you at our next event. See you all next time.